Good morning. My name is Alexander Schupper, and I'm a second-year neurosurgery resident at Mount Sinai here in New York City. The title of my research day presentation is 5-amino-levulinic acid for enhanced surgical visualization of high-grade gliomas, a prospective multi-center study. I do not have any personal disclosures related to the study. Dr. Hajipanias, who's one of the PIs of the study, is a consultant for NXDS, DC, who manufactures gliolin. We've known now for around 20 years, if not more, that the greater the extent of resection when it comes to high-grade glioma surgery, the improved survival our patients experience. Additionally, we know that 5-amino-levulinic acid, which I will call 5-ALA for short, can improve the extent of resection by enhancing the intraoperative visualization of malignant tumor tissue, not just at the tumor core, but also at the margins around the tumor. 5-ALA is an orally administered substance. It's actually a byproduct in the heme synthesis pathway from protoporphyrin IX, and it's converted within the glial cell. When it's converted by the glial cells into protoporphyrin IX, it accumulates intracellularly, and this produces a fluorophore, which becomes excited upon blue light. As we can see here in this video, when the blue light is turned on after the patient ingests gliolin, we can see here that the glial cells light up pink upon blue light, as you can see here. In 2006, Walter Sumer et al. Conducted a phase 3 randomized controlled trial that showed an improvement in 6-month progression-free survival when 5-ALA was used during tumor resection compared to controls who underwent resection in white light. Since this trial, 5-ALA has been widely available across Europe, and there have been multiple other multi-center trials since then, primarily from Germany. However, we have a lack of high level of evidence of the use of 5-ALA here in this country. Recently, in 2017, due to a large part from the efforts of Dr. Konstantinos Hajipanias, 5-ALA received FDA approval for the use in the US for visualization of malignant tissue during glioma surgery. In this FDA approval, the majority of the studies were based out of European trials, and there were no multi-center United States trials used. Here, we assess the utility and the safety of 5-ALA fluorescence by using a multi-center approach across many different academic and community hospitals throughout the United States for the first time. We have two primary arms in this study. The first is to determine the diagnostic accuracy, of 5-ALA-induced fluorescence upon resection for high-grade gliomas. The second is to assess the safety of 5-ALA. Additionally, we performed an exploratory post-hoc analysis to evaluate the extent of resection in our cohort. For this study, we use a cohort-based single-arm prospective multi-center study. We include all adult patients aged 18 to 80. Every patient had a KPS score greater than 60 with an MRI diagnosis of new or recurrent, surgically resectable high-grade glioma defined as WHO grade 3 or 4. Each patient had between 3 and 5 intraoperative samples taken, and the surgeon determined objectively the fluorescence status, either that there was fluorescence or that there was not. Patients were followed in the study for a 6-week period postoperatively for adverse events and changes in the neurological exam. As part of our post-hoc analysis, a volumetric analysis was performed, assessing tumor volume both pre and post-op. Our results are here in this table. We had 225 tumor samples in total, of which 218 of them fluoresced. Of these 218, 205 of these tumor samples were high-grade glioma tissue. We had a sensitivity of over 94% with specificity of 71%. In this sample, there was a 99% positive predictive value for fluorescence with an accuracy of over 93% and an odds ratio of over 39. Regarding the safety within our cohort, 2 patients experienced skin photosensitivity reactions and 1 developed a post-op fever that was believed to be possibly related to 5-ALA. 2 patients developed meningitis after surgery. 1 suffered a neurological decline secondary to tumor progression. There were 2 postoperative deaths, 1 due to shunt failure and 1 due to intracerebral hemorrhage following surgery. Regarding KPS scores, there were no significant differences in Karnofsky performance scores between preoperative baseline KPS and 6 weeks postoperatively. Additionally, there were no differences at our multiple time points at weeks 0, 2, and 6. In our post-hoc analysis, there was a mean extent of resection of 88% and a mean gross total resection rate of 64%. This is very similar to the gross total resection rate in Walter's tumors phase 3 randomized controlled trial of 65%. And this is right in the middle of the published GTR rate with 5-ALA use between 40 and 80% published this past year by Golub et al. In conclusion, 5-ALA was well tolerated. There were very few adverse events from the study, and the majority of them were thought to be minor events. 5-ALA was not associated with any significant decline in KPS scores when patients were monitored up to 6 weeks postoperatively. Additionally, we found that there was very high diagnostic accuracy of the use of 5-ALA in resection of high-grade gliomas. And then, like many other studies, this study has significant limitations. The largest limitation is that this is a single-arm study without a controlled group. Thank you very much for your time.